Ufridi is pleased to sponsor this informative program on non-surgical periodontal protocols. During this presentation, Dr. Sam Lau will provide you with the tools to appropriately manage complex periodontal patients. Dr. Lau is a professor emeritus at the University of Florida College of Dentistry and associate faculty member at the Pankey Institute, with 30 years of private practice experience in periodontics, lasers, and implant placement. Sam is passionate about the use of technology to advance non-surgical periodontal protocols and to achieving successful outcomes in the operatory. Now please join me in welcoming Dr. Samuel Lau.
Well, thank you, Patty, and also thanks to Ufridi for allowing me to share some of my ideas and thoughts in the direction of where technology can find its place in non-surgical periodontal protocols. Just about the time that I think periodontics may be at its lower ebb, then all of a sudden a study comes out demonstrating just how much periodontitis exists in the United States, North America, and indeed the world. And our objective this evening, and we'll be brief, is to basically look at the concepts on managing periodontitis. Notice I use the word manage and not the word treat. And this will come to connect the dots even more so as we move through our presentation. I think it's very, very critical that we differentiate between what is non-surgical and surgical and those expectations for each of those. And we will place our emphasis on the non-surgical activity, which will primarily be using technology. No technology is worth its weight unless there is a quality treatment plan, and we will pursue that. And we will try to put all of this together. In fact, we will put all of this together to assess, plan, implement, and evaluate based on the treatment protocols. To begin with, let's try to balance something called if periodontitis is an infection or indeed is it a chronic inflammatory disease. Many of us on this call tonight has witnessed what we see on the screen. You will notice that these are veneers, and you will notice that there is what we call the red halo around each one of those. And if I call your attention to where my arrows are, you'll notice a significant line of demarcation where the inflammation is. Now, my question to all of you on this call is this good or bad inflammation? Well, if you're the patient and even the practitioner, this appears to be bad. But as we pursue this whole concept of chronic inflammatory diseases, one will be able to appreciate that this red inflamed demarcation is actually a protective mechanism against something that we call the foreign body. And in this particular case, the veneers have become the foreign body, and the body sees this as a stimulus and tries to reverse it by calling out the inflammatory troops. Tonight, we want to balance something between that which is considered to be an infection, which indeed the stimulus is the bacteria, being the anaerobic, non-oxygen-loving organisms such as Porphyromonas gingivalis, and the stimulus to those organisms which we call the host response. And I personally am indebted to Tom Van Dyke at Boston University, one of our leading clinical researchers, who presented a paper in Journal of Periodontology in April 2014, in which he suggested that basically the challenge of the future in managing periodontitis is harnessing this resolution of inflammation. So therefore, when we look at this, we notice that there is calculus, we notice that there is what we call the biofilm, but we also notice that there is something called the response to this biofilm, which is the inflammatory reaction. Now, not to confuse you or complicate this with this rather involved slide, but the orange is the challenge and the green is the result of the challenge. A is what we used to think, B is what we thought most recently, and C is where we currently are. You'll notice that we still have the orange and the green, but in between those two under C is the blue, which is the host inflammatory response, the connective tissue and bone metabolism scenario. But there are two areas that truly affect where the orange gets to the green. And that orange to the green is primarily where the environment and the genetic risk factors definitely come into play. So with that in mind, let's you and I pursue what the public deals with when they think of periodontitis. For the most part, they think that it's a silent disease, an invisible disease. Most of them are totally unaware that they even have it because there is basically minimal symptomology with periodontal disease. However, when one considers that periodontitis is the sixth most prevalent disease in the world at this point, it has its own place as one of the major chronic inflammatory diseases of the human body, along with cardiovascular disease, Alzheimer's disease, and rheumatoid arthritis. You may be aware that the situation with chronic inflammatory diseases is primarily that which is the icon disease of the baby boomer generation. And that baby booming generation will dominate our practices right now and for the next 10 to 15 years. When one looks at periodontal tissues, and you notice over on the left screen, that is where we consider to be health. And you will notice that in that sulcus, it is totally epithelialized, versus what we see over on the right, which you see an interruption of that epithelium, literally pus coming out of the site, and a substantial number of cells around that inflammatory cascade. Those cells are not bacteria, my friends. Those cells are inflammatory cells beginning with hyperactive neutrophils, plasma cells, and to a certain degree, lymphocytes. So when one thinks about the sulcus, one begins to think about biofilms. Biofilms is no doubt the stimulus that creates the initiation of periodontitis, but the perpetuation of periodontitis to a certain degree occurs within itself. It's a self-perpetuation that continues on as we have any biofilms, not just the significant biofilms that we have with gingivitis. So with that periodontal disease and systemic link, with biofilms being the stimulus, one begins to project and takes a look at oral diseases, which are primarily for us tonight, being gingivitis and periodontitis, and the relationship of that with oxidative stress, and that with systemic oxidative stress with the other chronic inflammatory diseases that we have. I'm sure you're aware that oxidative stress is the result of free radicals looking for electrons, and when they cannot find those electrons, they rob it from healthy tissue. Now, I want to bring your attention to also something that we see every day in our practices. On the initial examination, again, you see this very bright red chronic inflammatory appearance, spontaneous hemorrhage on probing, actually spontaneous hemorrhage probably just seeing it, and then notice that 3 months later, using an antioxidant gel plus an ultrasonic debridement, without actually even changing the restorations, that there has been a fairly radical decrease in that inflammatory cascade. That antioxidant gel provides the electrons for the free radicals, and therefore we get a nice resolution relative to the gingival appearance. Now, we always ask ourselves, what is the primary result of periodontitis? And with that, we see the spread of infection, loss of teeth, the surgery, but for the most part, it actually is the irreversible loss of jawbone. So what I've given you, I think for all of us, it's very difficult to try to script out to patients what is periodontitis to the point that we get a positive case acceptance. And so let me turn that around for you. And I have been able to generate what I believe encapsulates what we think about with periodontitis. And periodontitis is the body's reaction to a stimulus. It's primarily biofilm. Tonight we will explore technology to manage that, or it also could be an occlusal stimulus. But the important thing is it results in an overactive response to produce inflammatory mediators. By the way, those are those lymphokine, cytokine activity that destroys our own healthy tissue. So what I put in there tonight is a provocative concept for you, and that is periodontitis an autoimmune reaction, an autoimmune patient condition? And I would suggest personally that it absolutely is. And if one looks from 1975, 85, 95, I call your attention to the here where you see the mesial of the maxillary central, and look what has happened to that central in 10 years, and what has happened to that central in 20 years, and let's compare it to the opposing central, its mate, and notice how there has been such a difference in the change between these two sites, very different, and in the same mouth. And I would suggest to you that this is site specificity. And so with that, this brings on the idea, the thought process of the three major environmental factors that help the genetic predisposition of the disease. And one is nicotine ingestion. The second would be diabetes. You'll notice that both of these are altering the neutrophil chemotactic functions. The neutrophils are primed. And lastly, our third one would be occlusion. Occlusion is absolutely crucial in the progression of periodontitis, and it must be managed some way, somehow. And I hope most of you have been able to take courses relative to occlusal signs and symptoms and the ways that we manage occlusion, whether it be through adjustment or night guards, and even in some patients, splinting when we see significant mobility. Now, through all this, one would be myopic not to talk about the genetic predisposition of our patients. You know, none of our patients are the same. Each one of them has a genetic susceptibility to the stimuli. And that genetic, we call that almost like a sleeping dog. And what wakes up that sleeping dog, that genetic predisposition, is the arena of the environment. And that being nicotine, diabetes, occlusion, various systemic diseases. So I hope all of you are moving your practice towards determining who's hot and who's cold, and not cookie cutting our management protocols that we have there for them. If I were to think about the most significant cue phrase that turns a patient on to accepting a periodontal treatment plan, this is what I have come up with over the last decade. And that is not your loss of teeth, not, as we sometimes say facetiously, floss or die, but basically it is the irreversible loss of your jawbone. You will note that I said, what is the ouch? Well, one has to have the ouch to have change. One sometimes says that without pain, you can't have change. So we've got to go what I consider to be the jugular if we're going to turn a patient on to accepting a treatment plan beyond the prophylaxis, by which we can do probably the most important objective, and that is to save their teeth. I know that all of you can appreciate, since most of you are hygienists, that our objective in dentistry is to save teeth. We only go to an implant treatment plan when that tooth is non-restorable or that tooth just cannot be salvaged from a very, very poor periodontal prognosis. But all of us start with, for the most part, wonderfully natural teeth. So there is a periodontal growth center in today's practice of dentistry. I still believe that that greatest potential is periodontics, primarily because we have a baby boomer population in our practice. Please do not give away periodontal probing. It is a value-based procedure that you do. Hopefully all of you have a diagnosis in the chart, because we cannot move forward without that diagnosis. And our thrust tonight is to discuss using technology to achieve the objective of saving teeth, but I know all of you can appreciate that is educating patients, is using the correct scripting to be able to turn them on to where we need to go. Now, when one talks about risk, turning that patient on to their risk is also critical. This is previsor.com. This is a wonderful risk assessment system that is very low cost, very user-friendly, all computer-based. And you might want to consider doing the demo through on their website. I have no financial background with this particular entity, although I truly believe, and my passion is determining the risk assessment before we move forward. Now, we sort of do this in our own amateurish way. We find out what is the familial history to get a genetic background. We look at medical status. We ask our patients, do you smoke or not? Although now I would hope that you would ask about any nicotine ingestion, not just smoking. That includes patching, chewing gum, what have you. Stress activity and our parafunctional habits leads to the whole arena of occlusion. And those of you in the United States where coding is quite important, the nomenclature from the ADA, I hope that you are using this D0180 code. It's a very important code, which is the Comprehensive Periodontal Examination Evaluation. And this is straight out of the descriptor from the ADA nomenclature, that it can be used on new or established patients, and it contains probing, medical history, and the overall health assessment. So tonight, this is about data collection to find out what we have, etiology to find why it happened, diagnosis to determine who has it, who doesn't, from the standpoint of aggressive or chronic, prognosis, what is the future, and then developing the treatment plan. That data collection is a cycle, and it includes the radiographic exam, probing, tissue characteristics such as minimal attached gingiva, and mobility. All comprehensive periodontal exams must contain these 4 arenas. With our radiology, the kingpin is our 4 vertical posterior bite wings. That is the minimal that one could have in a periodontal exam, supporting a FMX or a digital pan. Periodontal probing, the UNC-12 or the UNC-15 are considered to be the leaders in standards in periodontal probing. And here you see a UNC-12, UNC-15 by Hufridi. We also have our plastic screening probes. These are outstanding and excellent in showing patients. In our practice, we consider the green being as the green go light, the white area being an area where now we're in caution, and anything in the red we consider to be dangerous. Furcations are absolutely critical in periodontitis. From class 1 to class 3, we should find them. We should know where they are on what teeth, and we should know how our abilities to manage them. Our periodontal charting must be clean, it must be user-friendly. Naturally, my preference is a floater probe chart that you see on the screen. Since I have a financial connection, it is a conflict of interest to continue any conversation about it, but for whatever chart you use, it should be able to demonstrate to patients and any third party what our areas of concern are. Recently, Florida Probe launched VoiceWorks, which the hygienist is able to do a complete periodontal exam by going into the microphone and determining really where there is areas of concern. So once we have that examination, you and I move into what is considered to be flowcharts. Practices should not be hit or miss. They should be very organized and structured. And that patient should move through a flowchart system. As an example, this is a flowchart for our gingivitis patient. Tonight, we will place our emphasis on the periodontitis patient. And for those of you in the United States, I have placed our codes by these particular entities in the flowchart, moving from gross scaling. And again, I hope all of you are using a gross debridement as part of your treatment plan to be able to do the periodontal exam correctly and be able to do the root planing, ending up with the phase 1 evaluation. So now you and I move into phase 1 therapy and determine where technology can assist us in that primary objective of saving teeth. Oral hygiene is different for gingivitis patients and periodontitis patients. It would be naive for us to think that flossing is going to be able to have a major impact on periodontitis. It is time to move into other arenas of being able to remove those biofilms from the concavities that is so demonstrated in this slide of this extracted premolar. As I mentioned to you before, gross debridement is critical in reducing inflammation, reducing pocket depth, for us to have quality access, to get quality data collection, and to do quality periodontal debridement. The definitions of a cleaning are now not scaling and root planing. Our conversation will be provocative. Scaling is not what we do. Our teeth do not have scales. Root planing is not what we do. We do not root plane as if it was a board. This is a biofilm stimulated chronic inflammatory disease which requires changes in the way we manage a periodontitis patient. So today's categories of debridement are not scaling and root planing. They are gross debridement, gingival debridement for the gingivitis patient, and periodontal debridement for that periodontitis patient. We now believe that it is specific bacteria, primarily those gram-negative anaerobes. We now know that the disease is not linear after early periodontitis. The disease is not all through the mouth, that it is very site-specific, that endotoxins are not deeply embedded into dentinal tubules. And therefore, the therapy that we do for periodontal debridement, we're still going to remove calculus, but the level of trying to get roots glassy smooth is over. We're trying to detoxify a root, but not by completely trying to remove all the cementum and leaving dentin. Our primary objective is to create a biologic acceptable root surface, whether it be for long junctional epithelium, which is primarily what we get, to a connective tissue attachment. And therefore, how do we know if we've gotten the appropriate response? That's coming back to do the examination. I will not get into a debate tonight about which is better, a curette or a power-driven instrument, but to suggest to you that we have quality literature that demonstrates that they both are very acceptable. and that both of them can provide a quality end result. For the manual instrumentation, it's the thinnest gracies that you can have. The After 5 gracies are outstanding. Please choose instrumentation that requires decreased sharpening, that has quality alloys, such as the Ever Edge. We cannot spend a great deal of time sharpening our instrumentation. But now we're moving into another era, where ultrasonics are not just for gross debridement, but they are for all debridement. And there have been various devices that have been developed ever since 1955, when the very first ultrasonic was developed. So for heavy deposit removal, we're not going to use high power that sends a patient flying through the chair. No, we're going to use low to medium power settings, even for this patient, but we are going to use different tips. Tips that are considered to be triple bend tips, or tips that are standard piezo tips. For our medium to light deposit removal, here we're not even using a medium power setting, we're using a low setting, but again we're going to now our thin triple bends, and if you do not know about triple bends, please contact your representative, and our Perio designs for both the Magneto strictive and the piezos. For our periodontal debridement, again, low power setting, and now, thank goodness that our companies have come up with very thin periodontal designs, that which looks very similar to periodontal probes, to be able to get to the access. And so for the piezos, we have our Supragingival to our Supra, Subgingival to our Subgingival. And as you move from left to right, you will note how we continue to get thinner and thinner and thinner with these particular tips. When someone asks me, what should power-driven instrumentation tips look like? I always refer them to a standard. If your tips look like periodontal probes and Furca probes, then you are right on target. If your tips look like that which belongs in a large animal veterinary hospital, then you might want to reconsider the tips that you use. It is not about manual versus power-driven. It really is about the clinician, the techniques they use, and the very tips that they use to negotiate into these circular environments. That's where the proof of the pudding comes to place. So with our ultrasonic inserts, there are many companies that make very high quality instrumentation. And as you know, if you go immediately over to the right, I would say, I cut my teeth on that metal ultrasonic with the external water device, and some of us are still using those. But now we are moving into a level of sophistication with our tips, where you see the Supragingival, the orange being the 1000, which is an excellent triple bend insert, into our Supra subgingival inserts with our extra thin, and then moving over immediately to the right, in which we have our left and right and our straight inserts. These are outstanding inserts. They're curved in the right direction for us for access, and the RNLs are wonderful for furcation involvement. So that instrumentation protocol begins with a gross debridement, and please appreciate that if you're trying to determine between a manual or an ultrasonic device, I hope all of us would vote for an ultrasonic device for the gross debridement. That's where I will not create a mutual discrimination. Their manual instrumentation is just not appropriate in 2015. For our gingivitis patients, here I primarily, actually 100% of the time, use our ultrasonic devices, our thin triple bends, our universal thin inserts. whether they be for the power or ultrasonics or for our piezos. And then we complete that with our Supra and subgingival air polishing. Most of you, your objective for being here is about periodontitis. And in there we have our power-driven instrumentation. Again, thin triple bends, thin piezo tips, our Gracies being the after fives, and our Supra, and now the new kid on the block, the subgingival air polishing, and finishing with our traditional polish. This definitive debridement cascade is over several appointments. It is not a prophy. It begins with a gross debridement, following with a periodontal examination, following with half-mouth periodontal debridements. We try to do the right or left half, followed a couple of weeks later with the sequential symmetrical other half. We then wait approximately anywhere from 4 to 6 weeks for the reevaluation. 2 to 4 weeks if there's minimal debridement, 4 to 6 weeks if there is significant calculus. But you'll notice that one of the tricks of the trade is prior to any of these periodontal debridement procedures that we are doing a full 8 to 10 minute disinfection with the ultrasonic. That means going all supragingival and some subgingival before we concentrate on the particular areas of concern for that half mouth. So our technology for our supragingival can be any of the units that you see here using our sodium bicarbonate, calcium carbonate, aluminum trioxide powders. All of you know that the research demonstrates that these should not be used on dental surfaces. They can only be used on enamel surfaces, that they can have an irreversible effect with erosion of those dental surfaces. Where we are now is this whole arena of supra and especially subgingival air polishing. With this, not using sodium bicarbonate, but these innovative glycine powders, we have research that's demonstrating a significant disruption in the subgingival biofilms with subgingival air polishing. This is a very exciting area, not only around natural teeth, but now with some research that is being centered around implant mucositis. And these range from handheld technologies for both supra and subgingival to the arenas of using different types of delivery systems. This is one for subgingival, but actually aiming the tip actually a supragingival orientation, but it will go up to 4 millimeters. And you'll note this is using the glycine powder, not the sodium bicarbonate. So please, I am not advocating using sodium bicarbonate to do any level of subgingival air polishing. And then moving to these rather sophisticated tips that now can move subgingivally. And here is one of these tips with the EMS that is going into pockets deeper than 4 millimeters. And again, you will notice that we are using the glycine powder only in being able to do this. I wanted to also give you some thoughts about some additional technologies in addition to the power-driven magneto-stricted devices, the piezo devices, the supra and subgingival air polishing devices. Every now and then I get asked the question, well, can you do most of this with topical anesthetics? And my friends, when one has a true significant periodontitis patient, and that can be an early periodontitis patient, and is a new patient, topical anesthetics are generally not appropriate. You want to be able to do what you need to do without having any patient discomfort, because you're trying to build relationships with that patient, and you don't want anything to compromise your abilities to be able to effectively manage the biofilms and calculus removal in these particular areas. Whether that be local anesthesia with a syringe, or I would suggest that you might want to investigate these new, well, they're not new, but new to some practitioners, these ways of delivering local anesthesia. This one happens to be the STA system. You know it as the one by Milestone. And if you look in the upper right, this is just such a non-threatening entity in our ability to give local anesthesia. Local anesthesia for periodontal debridement, aka scaling and root planing, is no longer mandibular blocks or blocks. I hope you know that we have very creative ways of doing infiltration, whether it be a syringe or a wand-type device, and most of us are using half-inch 30-gauge needles. Now, to do this, there are some wonderful compounding topical anesthetics that are out there. There also are some wonderful topical anesthetics for subgingival use, such as Orachix. And I will leave that up to you, but primarily when one is using our topical subgingivally, this is generally on our periodontal management recare patients with isolated areas of concern. But for the most part, since they are not as effective on the root surfaces for our new patients, we generally use our local anesthesia. And again, I hope that you are using, that you have been exposed to local anesthetics such as our Septicaine, Articaine, which have profound transdermal effects. Lasers is one of my passions. And so for those of you who are hygienists that are in particular states that have a delegable duty for lasers by hygienists, I hope that you have your ear to the ground on the literature and can understand that they are the adjunctive use of lasers, particularly for hygienists, being the diode lasers, creates wonderful access. There is some limited literature on laser bacterial reduction, and I hope that you are appreciating that literature and determining if it can be adjunctive to you for what you need to do. A diode that I particularly use is the BioLace Epic X, and one of the reasons that I use that particular diode is also for its biostimulation abilities. And there is a reams of literature now in the medical literature and now into the dental literature on how our lasers do biostimulation and enhance the healing after our effective periodontal debridements with our, again, magnetostricted piezo and our subgingival air polishing techniques that we do. This biostimulation with laser enhances our blood supply, collagen formation, osteoblastic activity, and fibroblastic activity. So I hope that, again, you are apprised of where lasers may or may not fit with non-surgical periodontal care. Now, as we move into, after we have done our non-surgical periodontal debridement, and we move into this critical phase called the phase 1 reevaluation. There we look at several arenas. Again, this happens 4 to 6 weeks after our last quadrant of debridement. And in pockets that are 2 to 6 millimeters with significant debris, there we can do quality non-surgical periodontal care, and that ends up in our flow chart being a maintenance recare patient with an excellent oral hygiene score. For our patients that are highly susceptible, as you see on this screen, she's only 27 years old, has minimal calculus, significant pocket depths. This is not a non-surgical patient. This is a periodontal surgical patient, and with, again, an excellent high patient compliance score. However, we all have patients that are chronic inflammatory periodontitis with 2 to 9 millimeter pocket depths. This patient would be an excellent candidate for surgical care. Unfortunately, this patient has a very poor oral hygiene compliance score, and they will be moved into a non-surgical phase. However, we will put quality notations in our chart. So to recap this, our periodontal phase 2 decisions are pocket depths that are 4 to 5 millimeters, calculus, edematous, single-rooted, horizontal bone loss. But our surgical patients are depths 5 millimeters or greater, minimal local factors, fibrotic versus edematous, multi-rooted versus single-rooted, angular bone loss, and these are surgical patients. So when we move a patient from a non-surgical to a surgical phase, our phase 1 is outstanding in moving the left to the right, but as you can see, our molars still have periodontitis. There is a lateral that still has periodontitis, and this requires periodontal surgery. A patient who refuses a periodontal root planing treatment plan, please document. Records are critical. Attempt to establish rapport. As we said before, education equals treatment acceptance. But you cannot do prophies on these patients, even if they sign in their own gingival corvicular fluid on one of your consent forms that is generally unaccepted in a court of law. If a patient refuses periodontal surgery or to see a periodontist, still document. But here your periodontal debridement must be very competent. You must increase the frequency of your recare. You must place emphasis on your oral hygiene. Here you may want to go to local delivery antimicrobials, but your restorative care cannot be ideal. It must be compromised. So in conclusion, moving from that host defense versus biofilms to developing a quality periodontal management plan, including our technology devices, to moving to phase 1 therapy and deciding who gets periodontal surgery and who doesn't. Periodontitis is the result of both a biofilm stimulus and an inflammatory reaction. It is both an infection and an inflammatory reaction, and one must truly deal with both entities to be able to get resolution and to save teeth. The examination is key. Those radiographs, the pocket depths, the mobility, and the attached gingiva is crucial in determining the diagnosis. All patients must have a phase 1 plan, including all variables from risk assessment to prognosis. Technology in today's ability to deliver is critical to success. And the reevaluation determines everything on how that patient will be managed as they evolve into the periodontal management status we call periodontal recare. I've had several mentors so far in my quest to save teeth, and I am very indebted to the Pankey Institute, where I have taught for the last 25 years. Dr. Pankey had a mission statement that I think all of us can appreciate and still holds true now and will hold true for the next 50 to 70 years. The goal of my practice is simply to help my patients notice, keep, retain their teeth all of their lives if possible in maximum comfort, function, health, and aesthetics. Can ultrasonic scaling attain the same level of root planing as manual instrumentation? And that is absolutely yes. Every evidence-based study that has been done, and there have been many, demonstrates that ultrasonic debridement, I don't like to call it scaling, ultrasonic debridement gets the same removal of calculus and endotoxins and the same resolution of the inflammatory response as we do with manual instrumentation. This is a personal preference, and many of you out there may find that each complements each other, and you might consider doing both. What is the name of the antioxidant that I mentioned? This is Periosciences. If you go to periosciences.com, periosciences.com, you will find information on the AO Prevantage gel. Does a patient in ortho treatment, what part does this play in oral hygiene and self-cleansing and anterior open bite? The patient that I demonstrated the open bite, the patient was currently in orthodontics, and this patient was a mouth breather, and that had a major component to their final treatment. I was demonstrating the patient only in the interim phase 1 treatment. How can you legally charge a fee for periodontal charting in the United States? I'm not sure about the word legally, but there is, if you are in the United States, the D0180 code is a very acceptable code. It is part of the ADA nomenclature. It is not D0150. The 150 is used first, followed 2 to 3 weeks by the 180, and I hope that all of you are able to consider using that code. How significant is the soft tissue management protocol compared to today's periodontal evaluations? Soft tissue management was actually coined about 10 to 15 years ago as we began to do a deep dive into non-surgical perio. It's actually a misnomer. It's really not soft tissue management, is it? It's really not even hard tissue management. It's actually management of the chronic inflammatory disease process. And that's where I believe that we're moving in this direction. Are there new CDT codes for the new names of therapy? No. The gingival debridement will always be a pro fee until someone decides to change it, fortunately, because all of you know that you do a lot of debridements for gingivitis that go way beyond anything that is a prophylaxis. But for right now, it is a gingival debridement, and it is a prophylaxis. But then as we move into our periodontal debridement, that periodontal debridement is still our 4341 for the 4 or more teeth, and 4342 for less than 4 teeth. Those still are the mainstays of what we do in this particular business. Let me see if there are, oh yes, there are more questions. Can you please speak to why you do not use higher power settings on the ultrasonic? Primarily, I do not want to have a irreversible effect on the dentin. Remember, there's a complete difference between enamel and dentin relative organic versus inorganic. And we don't need to raise the power now that we have these outstanding triple bin inserts by our leading companies. And so we just rarely ever turn it up over low to medium with the devices that we have. Doesn't the polishing over time remove more enamel? Well, I think it totally depends upon the level the level of the grit, the abrasive factor of your polishing materials. But almost all of the polishing materials that we have now that are commercially available will not have an effect on enamel. My thoughts actually about supragingival polishing is that it's only for aesthetics. It has very, very little effect on periodontal disease. It is anything that is subgingival from a technical standpoint, whether it be polishing or mechanical debridement, that has any effect on the resolution of that. How does subgingival glycine compare to ultrasonic perio tips in 4 millimeters plus subgingival disinfection, efficacy, comfort? I can relate to the literature, and I can also now relate to personal experience with myself and our team hygienists, and that it is very comparable, that there is no significant discomfort, that our patients enjoy it. Efficacy, the studies are there that shows that it's equivalence. Now please appreciate that it will not remove calculus. That this is what we call, when we talk about subgingival disinfection, this is primarily the whole arena of the biofilms. In the area of why do a gross scale, the primary reason for a gross scaling is to resolve the edema and get into a more fibrotic area. You know, this thing of burnishing calculus, and I understand many of you are concerned with it, but burnishing calculus occurs with 2 or 3 arenas. One, not being able to detect calculus in the first place. 2, using a dull curette, which many of you know is an issue. And 3, with an ultrasonic, primarily using an area of where you continue to not know the calculus is there and using round instead of triple bend inserts. Triple bend inserts are crucial. This question about are you creating risk for periodontal abscesses, we get this question constantly. And in my 20 years of working with many hygienists, including my own practice, we have never seen one single periodontal abscess following a gross debridement with an ultrasonic. Where we saw it was a gross debridement with a scaler or curette, being able to develop that area. The AAP does not currently support lasers. And you're correct, but please understand that our organizations are only going to create policy based on very, very, very strong evidence-based and not new technology in a new frontier. But adding a laser to a non-surgical does create a certain level of access. And let's face it, doing anything to reduce the biofilm after you've mechanically removed it can only be an addition. Lasers with the right technology, with the right hands, with the right certification, I highly recommend the Academy of Laser Dentistry for your credentialing, whether you be a dentist or a hygienist. Is very, very positive. And there are studies out there that do demonstrate a decrease in the bacterial load with laser bacterial reduction. Now, whether it can be sustainable is another story, and we need research for that. The biostimulation question about it's a very exciting area. Biostimulation is now used in medicine, is used in veterinary medicine, it's used in chiropractic science. I use biostimulation post non-surgical and surgical debridement. It enhances the ATP production in the area of the mitochondria. And it's an area, again, that one really needs to pay some attention to for the future on how we manage wound healing. If we have 9 millimeter pockets, but good oral hygiene without bleeding and without chronic disease, what protocol would you suggest? And I would suggest to you that if you have a 9 millimeter true periodontal pocket, meaning that it is below apical to the CEJ, you have bleeding. You might not have coronal bleeding, but you have bleeding at the most apical part of that sulcus. And if one were to do a biopsy, you would have periodontal inflammation. Almost every histology study that's ever been done demonstrates that. So the protocol you would suggest would be a non-surgical protocol. I'm going to take just a few more questions. I'd like to know how significant soft tissue management protocol compares to today's evaluations. Are there new CDT code names? No, they're not. Do you charge for probing? Absolutely. And just to tell you, for my United States neighbors, we charge approximately $65 to $80 for that. What do you think of water flossers? I believe that you can have an adjunct to water irrigation, but you primarily must need mechanical, and that being interdental brushes such as proxy brushes. I'm a major fan of soft picks and adding that with medicaments. The Sulca brush in Toronto, Canada is one incredible delivery device for medicaments, especially around implants and restorations. What do I think about using certain other kinds of laser procedures for periodontitis? I think it still depends upon the technique and the clinician, and especially using it in the right cases that makes a difference. We personally do not use chlorhexidine for irrigation. We are concerned still about the adverse activity of fibroblasts with chlorhexidine, and we primarily use other medicaments that contain either menthol, thymol, CPC. Those areas are more of what we use for our irrigation. We do not run medicaments through our ultrasonics personally. However, I see no reason why one would not do that. There are devices out there that make that very user-friendly, and adding a medicament to your ultrasonic possibly could put the icing on the cake and decrease the recolonization. And we do not use local delivery antimicrobials as much now as we did in the past. Our practice is very laser oriented, and so we are using our laser in a laser bacterial reduction where we would have used local delivery antimicrobials in the past. Would I recommend a patient go through non-surgical therapy prior to being referred to a periodontist? That totally depends upon the ability of the clinician doing the phase 1 management treatment, and moreover, the severity of the case. If you know that it's a moderate to severe periodontitis and you're not going, and there's minimal calculus, your phase 1 is not going to have a significant impact. And if your practice does not do periodontal surgery, then one could immediately refer that patient to a periodontist to pursue a surgical treatment plan. If you evaluate at 6 weeks and you have 1 to 3 non-responsive areas, do you refer directly to surgical care? Or do you reevaluate again? If there is nothing on those roots, if those roots are calculus-free, local factor-free, it's time to do periodontal surgery, because to continue to perpetuate the scenario only creates more memory cells and continues the self-perpetuation of the situation. Are air flossers effective? You probably are referring to the Air Floss by Philips. They're extremely effective. I would ask you to go on the Philips website, look at their science relative to the counterpart of flossing. We do highly recommend the Air Floss. The difference is we put medicaments in the Air Floss. We do not dilute those medicaments. And it is a mainstay along with electric toothbrushing for what we do. Is there current research being considered regarding diet and the immune response? Unfortunately, there is minimal research. Unfortunately, there should be significant research on the relationship between nutrition and all chronic inflammatory diseases as we consider to be periodontitis. And I know as a fact that we will spend a great deal of time in the nutrition segment as we begin to look at patients from prebiotics to nutraceuticals in being able to manage and control to a certain degree periodontitis.